Good afternoon all. Today we have our fifth lecture, and this lecture is for ECG and myocardial infarction. It's a very important topic, and please pay enough attention to this lecture. So when we talk about myocardial infarction, we are talking about three things. In MI, we are talking about three things. One is necrosis, other is injury, and third is ischemia. So that means whenever there is a abrupt blood supply loss to a portion of myocardium, we have three things happening. One is necrosis, other is injury, and third is ischemia. So what we are doing is we are taking a cross section. In this cross section, this is the subendocardial area, subendocardial surface, and this is the epicardium. Left ventricle, right? So what has happened is there is an abrupt cessation of blood supply in this area. So whenever there is an abrupt cessation, there is a pyramid like formation of all these three areas. The middlemost area is of necrosis, which is depicted in red. Just lateral to the necrotic area is injury area, and just lateral to the injury area in green is ischemic area. So whenever we are placing a electrode, a lead, it will capture different waveforms for each of the pathologies. So that means for necrosis, something will be depicted in ECG, for injury something else will be depicted, and for ischemia something else will be depicted. So what is depicted? When we talk of necrosis, we generally see QS waves or QR waves or loss of R waves, right? When we are looking directly at the area of necrosis, we will see in ECG three things. One is either there will be a QS formation, either there will be a QR formation, or there will be loss of R waves. When we talk of injury, injury is depicted by ST segment. ST segment. So when we talk of myocardial infarction, we are talking about ST segment elevation. So ST elevation. ST elevation doesn't mean necrotic area. It means area which is immediately besides the necrotic area and which is injured. Third, ischemia. Ischemic tissue is denoted by T wave abnormalities. These T waves can be inverted, they can be deep and symmetrical like this, right? So whenever MI is occurring, we are talking of three things: necrosis, injury, ischemia. And necrosis is depicted by QS, QR, and loss of R waves. The injury is depicted by ST segment elevation, and ischemic area is denoted by T wave inversions. So suppose I put a electrode here. Suppose I put an electrode here. This electrode is not placed directly on the muscle. It is placed somewhat farther away from the muscle. So one concept which is very important to understand is what is known as intrinsic deflection and what is known as intrinsic coid deflection. So whenever we see a QRS, suppose this is a P wave, QRS T. If I calculate the time from the onset of QRS to the peak of R wave, this time, this is known as intrinsic deflection. But for this, the electrode has to be placed directly over myocardium. What does it mean with respect to intrinsic deflection? It means that the current which is traveling from subendocardial surface has reached the epicardial surface. So it is the time traveling from subendocardial to epicardial surface. So if I place my electrode just over the myocardium, it will take around 0.02 seconds in lead V1 and 0.04 seconds in lead V2. So getting the point? So current is traveling from subendocardial surface to epicardial surface. This deflection means current has started traveling from subendocardial to epicardial surface, right? Why there is a slight time gap? Because electrode is slightly placed away from the muscle. It is placed on the chest wall. So that's why it is known as intrinsic coid deflection. Intrinsic coid means similar to intrinsic. If I place electrode directly over the heart, this deflection will be intrinsic deflection. Now the electrode is placed on the chest wall, it is known as intrinsic coid deflection. It denotes the ventricular activation time. It is known as ventricular activation time. In V1 it is 0.02 seconds and in V2 it is 0.04. Anything beyond this will be known as increase in ventricular activation time. So where can we have increase in ventricular activation time? Say we have LVH. If the muscle mass is more, we'll have increased left ventricular activation time, right? This concept is clear? So when we talk of ECG changes in STEMI, these ECG changes can be classified into hyperacute phase, fully evolved phase, chronic stabilizing phase. Right? So an ECG will pass through various stages when we are talking of STEMI: hyperacute phase, fully evolved phase and chronic stabilizing phase. So as I said that necrosis is depicted by QS wave. So how do we get a QS wave? Now imagine this is my LV, this is my septum, this is my RV free wall. This is the area which has got infarcted, completely necrosed. This is a lead which is looking from this side. What it will look? There will be no traveling of current from here to here. So this is a dead area, or you can say there is a gap in the myocardium. This is activated, but this part is not activated. So what is happening is there is a gap in the muscle electrically. There is no real gap in the muscle. There is an electrical gap in the muscle. So now see, this electrode will see something going away. The septal vector is directed up and towards right. So it is up and towards right. Right ventricular free wall vector is directed again up towards right. So this will see something going away. So if I denote it as 1 and I denote it as 2, so this will see ECG like this: 1 and 2. Getting the point? Whole of the muscle is infarcted. There is an electrical gap. So what this electrode is seeing, it is seeing the septal vector, which is the initial vector. It always comes before the right ventricular vector. So it sees vector 1 going away. So there is a negative deflection. Then it sees vector 2, which is again negative. It goes like this. So this is a complete Q wave, QS pattern. So this is known as QS. So what is QS? It is complete transmural infarct. Transmural infarct. So whenever in any lead we encounter a QS, capital Q, capital S, it means below that lead we have an area which is transmurally infarcted. Now there can be a situation where there is no transmural infarction. Say for example, I have this ventricular myocardium and there is subendocardial infarction. right? There is subendocardial infarction. Again, septal vector is in this direction, RV free wall vector is in this direction. I have a lead here. If it would have been a complete infarction, then there would be an electrical gap. Now there is not a complete infarction. So what will happen is, as soon as this normal muscle will start activating, this won't. This won't. If it is not getting electrically activated, this will sense something here. This will sense something going away. So there will be a Q wave formation. I denote it as 1 and 2, 1 and 2. Now this remaining muscle gets activated. So something is coming towards the electrode. So what will happen? We will have this pattern. This is known as QR. Q is bigger than R. So this will be smaller. So QR. Right? So in any lead, if we are encountering a pattern where it is capital Q small r, that means the infarction is either subendocardial, or the situation can be like this. It can be subepicardial. The same thing. When we talk of electrical principles, having a subendocardial or a subepicardial infarction doesn't matter. The pattern will be exactly the same. Okay. Most of the infarctions are epicardial. That means they have a subendocardial rind. See, there is a gap here. This is known as subendocardial rind. So, despite having a transmural infarct, we have a small strip of myocardium which is electrically active, which is perfused by oxygen, maybe by direct diffusion of oxygen from the LV blood. So this is known as subendocardial rind. Okay. So this rind can be more. It can be here. If I have a subepicardial infarction, in that case I will have a QR formation. The third thing in necrosis is loss of R wave. What is loss of R wave? Loss of R wave means the amplitude of R wave decreases. Where it will decrease? Suppose I have an electrode which is slightly far off from the infarcted area. Suppose there is an electrode which is away from the infarcted area. So this current, injury of current, will affect formation of R wave in an electrode which is slightly farther away from your infarcted area. So it's one of the most sensitive and one of the most earliest sign of myocardial infarction that there is a loss of R wave amplitude. So if I have, say, in V6 P wave, this formation which is ideal, and I find that in my lead V6 I am having something like this, we have to get alert, right? V6 has a robust R wave. If V5, V6 R wave decrease in their amplitude without evidence of Q wave, without the evidence of T wave inversion, it should be taken as an ominous sign of development of myocardial infarction. So when I talk of necrosis, we are talking in terms of QS, which we understood, we are talking in the terms of QR, which we understood, and we are talking in terms of R wave magnitude. Now we come to ST segment. See, I'll take two leads, AVR and V6, just for convention. Okay, so I keep my V6 here and my AVR here. AVR V6. So how my normal AVR looks? My normal AVR looks like this. Negative P wave, something like this. Negative T wave. Okay, it is exact mirror image of or opposite image of lead 2. How my V6 looks? V6 looks like this. P wave, right? Now you imagine something. Suppose I have a problem in the subendocardial surface. This part gets infarcted. So ST segment, as we learned earlier, travels towards the site of injury. ST segment travels towards the site of injury. So my AVR will look like something like this. I have a ST elevation. See, this is an infarcted area. The current direction will be towards AVR. Okay, the ST segment will cove up in AVR, but it is away from V6. ST segment moves towards the infarcted area. So my V6 will look like this. So I have a ST segment depression in V6 and I have a ST segment elevation in AVR in my subendocardial infarct. If I have a subepicardial infarct, so things will reverse. What will happen is my ST will be elevated in V6 and my ST will be depressed in AVR. Getting the point? So this is a concept of what you call as reciprocal change. We always talk of reciprocal change. In myocardial infarction, ST elevation is of some significance. It is indicative of infarction going on. But in a lead which is 180 degree opposite to that lead, you will always find a reciprocal change, right? So when I talk of this, I will talk of subendocardial infarction here and a reciprocal change in V6. When I am talking of this, I will talk of subepicardial infarction with a reciprocal change in AVR. Bit difficult, but just understand that ST segment travels towards the site of injury. So ST segment, as I said, always travels towards the site of injury. Now we talk of T waves, right? So when we are talking of T waves, we are talking of ischemia. The T wave is symmetrical, pointed and deep. Symmetrical, pointed, deep T inversions are indicative of not injury but ischemic process around the area of myocardial necrosis, right? It can always may not be a part of ischemia. You can have LVH with strain, right? In LVH with strain, because of the strain of myocardial muscle, you can have ischemic zones. There you can find similar T waves which are found in a case of MI, right? So now we come to the stages of MI. Stages. The first stage is hyperacute. Hyperacute stage. So in hyperacute stage, I have increase in ventricular activation time. I have increase in R wave amplitude. Right? I have ST elevation and I have tall and wide T waves. Right? Increased ventricular activation time means intrinsic deflection is now more than 0.04 in lateral leads or more than 0.02 in right-sided precordial leads. See, this is a normal ECG, suppose. If I talk of hyperacute phase, what will happen is, let's do a P wave. This is classical hyperacute stage. What is happening is, see, here the ventricular activation time, if I calculate like this, it will be say 0.2. The ventricular activation time has increased. The wave has moved like this. The angle has become slightly more subacute. It was acute towards 90 degree. It is now moving less than 90 degree. So this time from initial Q wave to the peak of R wave has increased. Why it has increased? Reason is this. Suppose I have an infarction here in my left ventricular free wall. This is V6. Whenever infarction occurs, that doesn't mean that electrical current will stop flowing immediately. So it is flowing, but a bit slow. So current is flowing, but it is slow. It takes time to reach epicardial surface. It is taking time to reach epicardial surface, and that is the reason my R wave shifts like this. It is taking time. And when it is taking time, the peak of R wave also gets up. The intensity goes up because more time is being taken by R wave to develop. So it is going like this and it's going upwards. The more time it takes, the more higher it gets, right? Then I have a ST segment elevation. We discussed why the reason is of ST segment elevation, and we have T waves which are tall. This will progress further. What will happen is, after hyperacute phase is over, we will come to the chronic evolving phase. Okay, a fully evolved phase. In that you have development of Q waves. Your ST is slightly elevated. You have T wave inversion also. So what is happening is, this is settling down. This is settling down. Your T wave can be slightly positive or maybe negative also, but in a fully evolved phase, your ventricular activation time and tallness of R wave decreases, and there is development of Q wave. In a chronic stabilized phase, what you will get is, you will get a Q wave, a ST which becomes isoelectric, and maybe a normal T wave. So this is normal, this is hyperacute, this is fully evolved, and this is your chronic stabilized. So what is happening is, initially we have increased ventricular activation time, we have R wave amplitude which is increasing, we have ST elevation, and T wave is also elevated. This is a complex ST, T and QRS, not QRS, RS, right? This is one complex. Sometimes if the intensity of MI is too high, you have a bigger blockage, or there is a bad MI, you can have what we call as mergence of waves. Something like this. You will not be able to differentiate between your R, ST and T. It can be tall, very tall. You got the concept of R wave intensity, na? That myocardium is still viable. When we talk of ST waves, ST segment, I told you that we have P wave, PR segment which is absolute isoelectric. It's absolutely isoelectric. then we have a QRS, then we have our ST. If I magnify ST, it will look like this. It's not isoelectric, it is like this, slightly goes up and merges with the proximal limb of T wave. It's a smooth mergence. In fact, it will be like this somewhat. There will be a smooth mergence. What will happen in ST elevation? ST becomes slightly isoelectric. This is a fine point. ST is never isoelectric. If it is getting isoelectric, it means injury is there. You're getting the point? ST is never isoelectric like PR segment. ST, if it's getting isoelectric, it means some sort of myocardial ischemic injury is taking place. Then it becomes positive after that. Getting the point? So if you have a monophasic deflection wherein you are unable to identify R wave, ST and T, it's the same monophasic wave, it's a very bad sign with respect to MI. Sometimes we can have Prinzmetal's angina. In Prinzmetal angina also we have similar hyperacute phase, but it lasts not more than 20 minutes, right? You give treatment, it won't last more than 20 minutes. Trop I can be elevated, right? What is the significance of hyperacute phase? The significance of hyperacute phase is most of the ventricular fibrillations are bound to occur in this phase only. So you have to hit hard if you are having a patient of MI presenting to you in hyperacute phase. You have to treat him fast, either medically or through PTCA. Once you have fully evolved phase, then you have chronic stabilizing phase. Suppose in chronic stabilizing phase, someone comes to you with ECG changes and you see that I have Q wave in lead 3. Mind you, Q wave can be normally found in lead 3, which goes by deep inspiration. Once you inspire deep inspiration, your Q wave gets abolished because of the slight rotation of axis of the wave, right? How do you say that patient suffered from an old MI, old inferior wall MI, just by looking at the Q wave? So if the Q wave amplitude, Q wave duration is more than 0.04 seconds in lead 3, if the duration of Q wave is more than 0.04 second in lead 3, it tells you that patient probably had an inferior wall MI. If it is more than 0.02 seconds in AVF, it means patient probably suffered from old MI. Any presence of Q wave in lead 2 will never have a Q wave. So if you have a tiniest of Q wave, you should be always skeptical that probably this patient suffered from an MI. Beware that in AV and RT, you can have a negative P wave and short PR interval. A short PR interval and a negative P wave, which may look like a Q wave in lead 2. So your differential for Q wave in lead 2 will be AV and RT also. So the P wave should be positive. If you have a positive P wave, then you have a QRS like this, it is abnormal. If you don't have a P wave, you have a short PR interval with negative P wave, it means you are dealing with AV and RT, you are not dealing with a Q wave in lead 2. You are getting the point? Similarly, you can have negative delta waves. You know, delta wave like this. P wave, delta wave. PR segment is short, you have an initial delta wave slur in WPW. Sometimes you can have negative delta waves. You can have delta wave like this. but you have a P wave which is like this, right? So you have to keep this in mind when you are looking at Q wave morphology, that whether you are dealing with AV and RT or you are dealing with negative P wave or negative delta wave in WPW. So when we talk of anterior wall MI, it can be extensive anterior wall. Extensive anterior wall. In extensive anterior wall, you will have all stages, that is hyperacute phase, fully evolved, and chronic stabilizing phase in V1 to V6 and 1 AVL. In anteroseptal MI, you have changes in V1 to V4. In lateral wall MI, you have V4 to V6 and 1 AVL. Why 1 AVL? We have talked about this in our first lecture, where we talked about placements of lead, that 1 AVL looks in my axilla, left high free wall, right? Then you can have apical wall MI, right? In apical wall MI, you can have, say, V3 to V5 or V4, right? So depending upon the position of leads, you can identify which type of MI you are dealing with. Now we come to posterior wall MI. Suppose I have an infarction here, right? The current is like this. If I did not have an infarction, the current was like this. If I have a lead here, suppose, right? If I had a lead here, so I'm looking it from the top, like this. I'm looking it from the top. So this is my right ventricle, this is my left ventricle, this is my posterior wall of LV. Posterior wall of LV is the last part to be depolarized, right? Current flows from apex to the posterior and basal surface of the heart. So if it's a normal phenomena, I'll have a normal ECG like this, correct? 1, 2, 1, 2, this is 3, this is 3, right? So this is a normal ECG. Suppose this gets infarcted. So what will happen? Suppose this is my V1. Everything is positive, nothing is going away. Everything is positive, nothing is going away. Current of injury will be looking towards the site of infarction. ST segment will move up. There will be no negative, nothing will be negative. So it will be like this. Right? Nothing is negative. That doesn't mean that infarction is here. It is the fully evolved phase of posterior wall. We just have to put a mirror. If we put a mirror, what will happen? It will look like this. So if you have a ST segment elevation in V1, isolated ST segment elevation in V1, you should rotate your ECG, look it as in a mirror. You will find it like this. This is telling you that patient had posterior wall MI. This is not telling you that patient had posterior wall MI. Getting the point? It's a fine point. So you either get this complex or you get something like this in V4R. V4R is here. So something like this in V4R is again suggestive of posterior wall MI. If we talk of inferior wall MI, isolated inferior wall MI is technically not possible because right ventricle is thin, it is very elastic, right? It is not thick, so oxygen can diffuse directly from RV cavity blood. So isolated IWMI is very rare. But if you see studies, 30% of patients of inferior wall MI has necrosis of right ventricle. There is some necrosis of right ventricle in 30% patients of inferior wall MI. So if I see of ECG prognostic guides, what ECG, how does the ECG tells us about prognosis of MI? If I have multiple MIs, means I can see inferior wall QS pattern, I can see anterolateral QS pattern also, that means patient has suffered multiple times MI. So it's a grave sign. If you have bundle branch blocks, so if you have LBBB, so LBBB pattern is bad prognosis in MI as compared to right bundle branch block, right? If you have extensive infarction, that means I have QS pattern from lead 1 to V6 and 1 in AVL, so extensive anterior wall MI, it's a bad prognosis. If you have any AV blocks or you have ventricular extrasystoles, which predisposes a phenomenon known as R on T. Ventricular extrasystoles during MI can precipitate R on T, which can give rise to ventricular arrhythmias. Right? So you have to remember that there are certain things by looking on ECG itself, you can tell the patient that this is a very high risk patient or a moderate risk patient. If we talk of say atrial infarction, so in first lecture we learned that it is the PR segment which tells you about atria. So what will happen? It will become like this. Can you see the difference? This is known as PTA segment. PTA segment. The elevation of PT atria segment. PTA. It is known as atrial infarction. Right? So whenever you have right coronary artery which is involved, which is high right coronary artery, you can have atrial infarction. You can find that your ST is elevated like this as compared to your PR segment is elevated like this as compared to your different areas. Sometimes you can have a patient even after months is coming to you with ST elevation and Q wave and T wave inversions or T wave abnormality. That means chronic stabilizing phase has not yet reached. It is still in fully evolving phase. So that means we are dealing with ventricular aneurysm. So persistence of Q wave with ST elevation constitutes, say after 3 months, if you are not getting a ST segment which is depressed, it means you are dealing with ventricular aneurysm. So I think we'll stop here, and next time if you have any questions we'll discuss regarding MI. Thank you.